Here's our agenda. It's very jam-packed. It's very quick. Justin told us he's coming in hot, and to which point I said, he's always hot. Hey. So we're going to basically do a little bit of some introduction. I need you to do some polling. We have Myopia Early Diagnosis Treatment Strategies by Dr. McGee. I'm going to talk a little bit about eyelid margin and focus on Demodex blepharitis and some MGD. And then we're going to have some customizing care for long-term success on the ocular surface with Justin, and then we're going to round it out with a little presbyopia, new treatment paradigms. All of these are things that if you're practicing optometry, you absolutely 100% have to be involved in. And in one way, shape, or form, because this is transforming the way that we practice, and more importantly, we have a lot of opportunities to help our patients. And then we're going to recap with a little bit of audience polls and discussion. This is a COPE approved accredited for continuing education. Your normal way of normally getting COPE, you'll be able to get that. Here's our learning objectives today. Identify patients at risk for the conditions we just discussed. Okay, customize treatments based on patients' conditions. Implement adaptable, practical management, focusing on the progression, and more importantly, enhancing our patients' quality of life. Much like I feel we're doing here right now with this hour, we're enhancing your quality of life. You're welcome. And lastly, apply the latest treatment options and technology to improve patient care. So here are our financial disclosures. You'll notice that Selena's is the biggest, which just means that she's a baller. I'm just telling you. So Justin, Cecilia, and I need to talk with her later and see how we can hook up with some of these companies and become visionaries like she is. More importantly, we also have the TGS staff, has no financial interest involved here. I'm going to hand this over to Dr. McGee, and Selena's going to take us on this journey. It's going to be fast and furious. We're all going to be like Justin, coming in hot. So be ready.
Buckle up. Here we go. Welcome. Thank you guys for coming. I'm super excited to be here, and I'm also excited that we have some definitely state-of-the-art myopia people in here, but we have a lot to learn. So we are going to kind of fly through this. There's only one wrong way to do myopia. What do you think that is? To not do anything at all. That is the only incorrect way to manage myopia, is to give your 7, 8, 10, 13-year-old a new pair of glasses and say, I will see you in 1 year. That's the yesterdays of how we practice and manage myopia, because this is an epidemic. I'm not telling you guys anything you have not heard that you already don't know. We had a whole half a day to start this conference off on myopia, so we're not going to get into all of the things, but what I really want you to walk out of this room with is A, the confidence to do this, and B, what to look for next in how you're going to plan your strategies and your implementation for myopia management. That's my goal for our 10 minutes together, because we know this is becoming a massive epidemic. And when you look at, it doesn't matter your demographic, it's pervasive in everything that you and I all do every day. When we look at identification, and again, this is what you guys had come into the survey with, also the factors that are related to this. It has everything to do with how old our kiddos are when they begin myopia, because every year of progression adds to that end number. Ethnicity, of course, genetics play a role, and then lifestyle and how much they do on their iPads. And the world has completely changed since 2020 and in 2007 with our iPhones. So to say all of that and look at how do we talk to parents, that's my biggest challenge, is when I talk to parents about this, right? And it's not typically the parent that is the -8, the -10, like they totally get it. It's the parents who are low myopic or emmetropic and their kiddo. I have a 17-year-old right now who's a -8. And for the parents to understand and say, well, I'll just get him LASIK when he turns 18, right? How many people in here have had that conversation and that was the response, right? I see a lot of head nods. That's super frustrating. And you throw a +8 in front of that parent's eyes and go, okay, but your child sees the world like this. And that's just the beginning of the story. What's gonna happen in 5 or 10 or 15 years when you're at 348x times of getting what's basically macular degeneration at the age of 30. I mean, we all have managed and diagnosed patients with myopic maculopathy, And it's heartbreaking to tell a 28, 30, 35, 40-year-old, this is the best we're gonna do, and it's probably gonna get worse, and you're already 20, 40, and I don't know where we're gonna wind up. And that's the path that we're on with all of our kiddos. I have a 14 and a 12-year-old. Luckily, right now, they're emmetropic, and I'm myopic, but I was that kid that had their nose in a book. Shocking, I know. I know you guys will be really surprised by that. Right? And I wound up being a -4 because of all of my near-related activities. But this is a public health epidemic that no one is really talking about until now. And we are really starting to get some groundswell. There's more things happening nationally, internationally. You know, this is part of the WHO, and I'm not gonna get into all the politics of that. I'm gonna steer clear of what's happening. But the things that we do in our practices and getting this message out to our parents and our grandparents is where this really matters. And what we care about is axial elongation, right? And there's all of these arguments, and you'll look at, you know, 3 studies that say this, and oh, you have to follow axial elongation. No, you should do it by refractive error. The bottom line is just do something. Refractive error, it's plus or minus 50 with any refraction. We have to cyclopage the kiddo, right? It's much more subjective. Axial elongation works great for management. It's not that you have to have that equipment in your office. I don't. I send my kiddos over to my surgeon and they do axial length on their IOL master. So it's not equipment that I even have in the office. We just manage it in that way. So you can be creative even if you don't have the technology in your office, because you all have a phoropter and you all have the rest of the equipment. So just understanding this and looking, I mean, this is just how big it's gotten. When you look at your phone, there's actually I think this came through, last summer, when this app came through on the iPhone that it's too close and you need to back it up. That automatically is loaded into every Apple phone at this point. So companies are even jumping on board with this. And prevention is important. And so this goes back to, do you have a protocol for visual hygiene? That's something that we can talk to all of our parents about, soon-to-be parents. If you have people, I have this conversation when I know that mom or dad is myopic. Hey, listen, when you decide to have kiddos, like, make sure that I see them at 6 months, 3 years, 5 years, and here are the things to help prevent myopia, because they're already at risk because you're myopic. And so that visual hygiene and our patients about that is super helpful. We know that once you get myopia, that we can't reverse it. We can help slow it down, and the outdoor time matters, but it doesn't matter as much until we get it. And so having that visual hygiene piece of education, I think, is super important. One of the challenges, and there's multiple ways to manage myopia, right? We do orthokeratology, we do soft contact lenses, we have spectacles, and there's more spectacles coming, there's atropine. But one of the biggest challenges that we have is we don't have atropine that we can send someone to the pharmacy for, right? This is a formulation that has to be reconstituted, and there's multiple studies, and this is one that my good friend Aaron Tamiyama did, looking at 9 different concentrations of atropine that we're giving our patients, and it's all over the map of the concentration, because atropine is a finicky molecule. It has to be stored at a low pH. There's a lot of things that go into that, and depending on how they're reconstituting it as well, when they are formulating this, you don't know what that kiddo is getting in that time. And I have to hypothesize that maybe that's why our studies are all over the place. It depends on where they were getting their atropine, and were they getting it from the same place during the whole 7 years of that study, right? So there's a lot of questions that we have around atropine. I'm not saying don't use it. I'm saying that we need a formulation that is consistent. And hopefully in the next 18 months, 2 years, we're gonna have that. And so I want you guys to be unaware of that, because this is something that you can use standalone. You can also, utilize it alongside your orthokeratology and your soft lenses and your spectacles. So it's something that's a yes and. Stay tuned, because there's more coming here. We know that ultimately what we're trying to do is create that peripheral defocus on the retina to slow down the axial elongation. That's what we're trying to attempt to do with all of these. And again, there's multiple ways to get there. We do not have time to go into all of that. This was my very first patient that I started years ago on orthokeratology, actually. So he came in, he's 8, and his prescription 20/40, he's -3, -350. He's a white Caucasian male, mom and dad. Both are, I think his dad's a low myope, mom's an emmetrope, and she's got 3 kiddos. He's the oldest, and he came in with this prescription 6 months ago. She had his prescription in her hand of where he had been. So he's already 8, and here we are, 350 and a 3, and he's changed in 6 months to a 4 and a 450. I mean, this kiddo is on his way to being a -10, right, ish, -8, -10, probably somewhere in there. Ocular health is unremarkable. What are you going to do with this kiddo? He's 8. He's a baseball player. You're going to give him his glasses and say, I'll see you in a year? We know that when they're left uncorrected, they change faster, right? So there's spectacles available. We can do soft contact lenses. He's an athlete, so I love orthokeratology when I can do that with an athlete because it's one less thing that they're managing in the daytime, especially if you've got swimmers. I don't want a swimmer in a soft contact lens, right? And so orthokeratology is where we went with him. And I can tell you this kiddo is 15. No, he's 16 because he's driving now. So he's 16 now. And there's all of his maps through the years. And I have kept him, ultimately we want to keep him under 26 millimeters of length. He is still under 26, and I have kept him at a -3 and a -350. This works. Mom and dad are super happy. He's happy. He doesn't have to deal with anything in the daytime. He's got great vision 24/7. And little brother wound up with orthokeratology, and the youngest brother has high astigmatism in one eye and plano in the other eye. And so for him, we have a little bit different approach. But this is just a perfect example of kiddos that are coming into your practice all day, every day. So yes, question. He wore glasses coming in to see me. Now with orthokeratology, he does not wear anything in the daytime. So he's 2015 with no correction in the daytime. Yep. So again, just to sum, because I have 20 seconds.
Actually, it's the counting up, so you're over. But go ahead, take the 20 seconds.
So to sum, for all of you who put in there, I'm not super confident, that is okay. There's a lot to learn in this space, but don't not do anything because of uncertainty. There's a lot of data out there, and anything that we do to help slow this down is going to help those kiddos. Thanks.
You know what I just realized? The way this is organized, we start with the spinning and grinning, right? The refraction. Then we pull the slit lamp in, and now we're going to look at the lids. We're going to talk ocular surface, and then we're going to think about inside the eye for presbyopia. So whoever put this together, brilliant. I don't know who did it, but here we are. So let's talk about Demodex. Okay? This might be a condition you've never heard of. If you are living in a closet or you just go la 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 la, not listening. This is obviously a pervasive and prevalent condition that's affecting literally every breathing person that walks through here. Every patient of yours has Demodex blepharitis. You guys all try to pretend it's not happening. You don't want to think about it. Your patients get sieved out about it. But I think you have to find the words and the narrative to help your patients, because we're seeing so much more data that indicates that a lot of the symptoms that our patients have had that we thought were dry eye related symptoms or just normal asthenopia, uncomfortableness, itching, redness to the eyes may actually have its root in Demodex blepharitis. I will share with you that most of your patients got Demodex from mom or dad, right? When dad was doing his like face to chest thing, which I never do with my kids, which is why I don't think we're that close. Moreover, you would get it from dust mites. There might be in the eggs, might be in dust mites. So this is something that has been there forever. Everybody has it. There are studies that have been done that show that 56% of patients with cataracts have Demodex blepharitis. And obviously, as we age and develop cataracts, 60% treated with dry eye also have Demodex blepharitis. But 93% of your patients with contact lenses also may have an intolerance to the Demodex blepharitis. And this was a study that was done, it was called the Atlas study that they did, where they just looked at consecutive patients, and the vast majority of those patients had the collarettes. And what do I mean by collarettes? I mean this. This might be one of the most challenging diagnoses, okay? Selena's talking about, refraction, okay? That's hard, right? And we talk about, maybe some other things, but to have the diagnosis of Demodex blepharitis, you have to really challenge yourself as clinicians. You have to ask the patient to look down, and you have to look at their lids. I know, am I right? That's so hard. It's the second hardest thing we do next to neurotrophic keratitis, where you actually touch the eye. You have your patient look down, you focus in. What do you guys put, do you change the mag on yours? 10 mag, go across?
Should be seeing it, so
Yeah.
sometimes I'll.
Okay. Justin, you change your mag?
I typically do.
Yeah, I don't. Selena and I don't. You two do. We're right, they're wrong. You don't need to change the mag. Okay, literally you go in there, you cannot miss these. This is Demodex shite. It's literally, it's everything you think it should be. It's like the Demodex explodes, leaves it all out there.
Hey, Mark, go back for a slide for just a second, just to really drive your point home. So those images, that top left image is my patient looking straight ahead. Top right is 10x, and then 16x in the bottom left, and 25x in the bottom right. So I don't like 25x. I can't see the forest for the trees, right? And so I like to live at 10x. I can see it on 10 or 16. I don't think you have to change it. You can, but it's not a have to. But what you do have to do is have the patient look down.
100%. Because this is my patient, Selena, and so you can see when they're looking down, you absolutely can see that. And I even focused in on the base of the lash with that collarette. Did you do that? No, I don't think you did.
So you changed the mag though?
I think, what's that?
It looks like you changed the mag though.
Oh!
I mean,
Thanks, Justin.
So, anywho, there was a study that was done by a company called Tarsus. I love when I can stand up here and say there's one treatment option. Okay, there's one thing that bona fide will kill the Demodex. Okay, you have other treatment options that manage it, other ones that kind of skirt around it, and they're not terrible, but there is a prescription medication that comes from Tarsus. It's called lotilaner. There's Saturn study, Saturn 1, Saturn 2. Here's their study results. Collarettes are basically based on the 150 lashes we have on the upper lid. You count them out, 0 to a few is like a 1, up to 10 is like a 2, and then up to 50 is like a 3. Am I doing the numbering right? And then when you get to 4, it's like 100, 150. The point being is that if you look at the data up here, in their Saturn study, using 6 weeks, twice a day, using lotilaner, they were able to take patients who had, on average, 100 lashes covered with collarettes. Okay, now imagine you went to a restaurant and there was like 100 little things stuck to the glass that you're about to drink out of. Would you send it back and say this needs to be cleaned, or would you just go, oh, I'm sure it's okay? Think about that on your patient's lashes. It's nasty, okay, the nasty. And they did their study, they found 50% of these versus the 10% vehicle went from about 100 follicles to less than 2. But then if we take it to about 10, you see that that number increases to about 80%, okay? 0 mites was 60%. So look at the very bottom one down there, 85% compared with 28% vehicles. 50% of these basically compared with that, 60% versus vehicle with completely 0. The stuff works. The second thing they looked at is redness. Now, I don't get too excited, I can't speak to the panel here, but I think there's so many other things that cause redness for our patients. But if there's something that actually helps to reduce some of the redness, where the patient perceives their eyes look healthier, then you know what, I'm excited about it, and as you see in here, there's a 25% reduction in that. If you're managing Demodex blepharitis, I think the number one thing that holds us back from treating it is the same thing that Selena said, is you're not doing anything about it. To me, if you see a Demodex, if you see collarettes, if you see the alpenglow sign from Laura Perryman, then you have to ask yourself, why am I not managing this in a manner that's going to help my patients remove some of these symptoms? It's quite simple. Okay? I have a little more time than you guys do, but is there anything you guys want to add about Demodex? Excellent. So, if you think about it, one thing I didn't mention is that Demodex is both brevis and folliculum. The folliculum are the larger ones that are actually in the follicles. Hence, those are the ones we see with our lashes. The brevis are much smaller, and they are in sebaceous glands. They're deeper in places like meibomian glands, on your face, in the oils. There's a lot of research right now to indicate that by removing the Demodex on the skin or in the sebaceous glands can actually help meibomian gland dysfunction. In fact, there was a study that was just published, and I can never remember the name of them. Ursa and Rhea. Okay? And in this study, what they did is they basically said, let's take patients that have Demodex blepharitis, but also have meibomian gland dysfunction. And how do they know that? Because the glands are capped or because they're inspissated, they still can kind of secrete oil, but the lipid looks turbid and it's no bueno. And they also did something that I thought was really, really clever in this study. They did patient-reported outcomes. They used a visual analog scale, and unlike the way I think of it, it's not a vision thing, it's visually. You look at a scale, 0 to 100, 0 basically being, oh my God, it's amazing, 100 being, this is the worst thing ever. And they asked them about itching. They asked them about redness. They asked them about fluctuating vision. And they also asked them about redness, itching, fluctuating vision, and there was one other, okay? After, what they did is 6 weeks with lotilaner. They found the exact same results that I just showed you from the Saturn studies, where the patients had reduction in their collarettes. But what they also found is that there was clinically significant improvement. Oh, meibomian gland yield secretion. They found clinically significant improvement from patients reporting in the redness, the itching, the fluctuating vision, as well as in their ability to kind of produce oils. So there is something there. That seeing patients that have Demodex, you should also look for the concomitant use of this with your patients who have meibomian gland dysfunction, even though it's indicated just for Demodex. But talking about meibomian gland dysfunction is quite simple. Push it. Push it real good. Get in there, push on those lids, look for some juicy something disgustingness, let the patients know you vomited in your mouth a little bit, get them excited about this. I mean, I still to this day love squeezing on glands and just telling them, oh my God, I wish you could see what I could see. And then I'll squeeze out some mayonnaise. I go, it looks like this. And we have options to treat this. You have to heat up those glands. You got to get those glands secreting a little bit better. So we have things like thermal pulsation, which controlled heat and pressure to liquefy the glands and expresses the meibum. IPL therapy, which my panel up here is a lot better versed on, which uses bursts of intense light to reduce the inflammation, kind of seal down some of the inflammatory neovascularization or small blood vessels that go to the meibomian glands, targeting that abnormal blood vessels, and then also manual gland expression. You have to be doing something in your practice. And part of the reason why I think this is so relevant and important is because there's not a lot of adherence to the things we ask our patients to do. A 6-week course of a drop, I can do that. Be on a drop twice a day for the rest of your life? No, thank you. For patients to sit there and say, do warm compresses, heat masks, they start doing it, but about only 40% of patients actually continue to do it. So when you can do a procedure in your office, then you have 100% compliance because you did it. Okay, and if you're not doing it in your office, something like the old way of doing it, automated vector thermal pulsation, right, where we put that bladder on there, and if that gentleman up there looks familiar, he's just any other bald white guy who just happens to be standing in the back, okay? We have other ways of doing this where we can do intelligent heat and manual expression. Within here is where you actually can use these smart lids. They work on the outside of the eye, and they heat up the glands from the outside. What's beautiful about this procedure is your patients are doing this in an open room. They can open their eyes, they can blink. And what's interesting also about this and this company is that they just concluded a clinical study. It was a 2-year study trying to compare using intelligent heat and manual expression to compare it against the standard treatment that we do for dry eye. Now, why do you say dry eye? Well, I'm going to tell you why dry eye. Because there are no medications that are approved for MGD. There's one on the market that specifically targets what affects our evaporative dry eye, and that is perfluorohexyloctane. And perfluorohexyloctane acts to kind of mimic the meibomian, but it's still indicated for patients that have dry eye. So in that particular instance, if you take cyclosporin 0.05%, and your insurance companies will pay for it, this study, called the Sahara study, is a 2-year study where they literally went in and said, let's do 6 months worth of 0.05% cyclosporin twice a day, and then let's do 1 treatment of this procedure. And at the end of the study, what they found is that tear breakup time was improved, clinically significantly improved, versus Restasis, or 0.05%, with this procedure. But every other metric, OSDI, as well as Schirmer scores, and also looking at corneal staining, were the exact same. So it was non-inferior, meaning that doing 1 procedure is the same, but you get better tear breakup. And this company is hoping that insurance companies will then make this part of their plans, give it a specific code, and enable us to be able to do this under insurance. Some of you might be saying, no, I want my cash pay. But for those of you like me, who the first question is always, is it covered? I would rather have the opportunity to help my patients that way. So here's an example of a case of mine. This is a patient who's a 43-year-old speech pathologist. Her eyes are terrible, they're red, painful all day. She says she's allergic to drops, which is always code to me, I don't want to take it, or it's too expensive, right? I tell people I'm allergic to chicken just because I just want the steak, so that's how I roll. I really actually am allergic to chicken, but everybody always goes, oh, sure you are. She's using lubricating drops 4 to 5 times a day, and it barely gives her any relief, no systemic or ocular health history, and she's really anxious and very skeptical. So she was offered the opportunity to do that vector treatment. She didn't like the idea of having it on top of her cornea and not being able to kind of like feel in control. So I talked to her about doing the other procedure, okay? Using the intelligent heat and using the manual expression. If you look at her data here, her Sandy was horrible, her tear breakup time was terrible, and her OSDI was ridiculous. Her physical exam, 20/30, 20/40 vision, she had a low tear meniscus, her tear prism was low but not terrible, and the staining was inferior as we expected, but look at her meibomian gland secretion scores. Out of a scale of 0 to 3, 3 being perfect, 15 glands should be 45, she had a 7. Terrible. And here's what my impression was, meibomian gland dysfunction, in-office gland expression was advised. I told her that I wanted her to use some emulsion-based lubricating drops and also to use a lid scrub as well as yes and moist heat mask. Okay? So I also prescribed her perfluorohexyloctane. And I always prescribe that, especially with any of my patients that have MGD, after a procedure I do because I want to stabilize what we did or reduce some of that inflammatory load. I brought her back for a 1-month follow-up. And I know sometimes you guys probably think these numbers are BS, but they're not, okay? This is life-changing. My eyes feel so amazing. Okay, I'm better now. The drops felt like silk. I've never seen as well as I have after these drops, and more importantly, your vision was 20/25 and 20/20. So the combination of those 2 treatments, putting something on top of her eye, reduced the corneal staining, and basically her meibomian gland secretion scores were improved as well. But look at her post-treatment here. Her Sandy score went from a 78 to a 5.
Wow.
I know. These are the ones, this is like for you golfers out there, you know, where you get one good shot and you're like, oh, hell yeah, let's golf, right? That patient right here turned me around. And I am a firm believer that if we can keep these in our practices and manage them in a different manner, utilize the tools and the things we have, our patients will significantly benefit. Demodex, you see one collarette, it's too much. Have the conversation with your patients, it's worth it. Meibomian gland dysfunction, you push on the meibomian glands, it doesn't come out looking like olive oil texture, then ask yourself, what else can I do? And distill something from Selena, yes and. I have more time because the time is going up, so I'm going to keep going. All right, I'm going to bring Justin up. If you have any questions, save them for yourself. All right, here comes Justin.
While Justin is switching, I think it's also important to mention that, look, all of our practices can't necessarily have these treatments, and it's okay to refer laterally to your optometry friends in the community.
Intra-optometric referrals.
Yep.
It's a beautiful thing.
It is.
Well, I'm going to actually kind of piggyback on a lot of the things that Mark talked about as we're going to continue on the ocular surface disease standpoint here, looking at more customized long-term success. And obviously, Demodex and meibomian gland dysfunction and all those types of things matter when we're talking about the surface of the eye. For all of you, if you're thinking you don't have a dry eye practice, everyone in here has a dry eye practice. You don't have to have a center of excellence to be managing dry eye. And so I'm going to focus a little bit on that as well, because I think at times we do overcomplicate how do we diagnose dry eye. And I don't want to simplify it because it's a complicated condition, but I think for some of you that are maybe just dabbling in it and how are you managing it and so on and so forth, there's a simple way to think through this, and there's some great technology out there. But when we look at the different technologies we can use to diagnose, you probably initially don't need to have every technology out there to make an accurate diagnosis. And so I kind of think of it in the simplest terms of there's 4 things you probably need. A dry eye questionnaire. I think it's important because it drives the conversation. It forces the patient to say, I'm having symptoms. Some do, some don't. 50% of patients will, 50% of them won't. Having vital dyes. Really simple, inexpensive. We all have them in our practice where we can look at tear breakup time, tear meniscus height, see what's happening with staining. A slit lamp. I hope that everyone in here has a slit lamp if you're managing patients in your clinics, and so that's an easy one. And then a digit. Mark mentioned this. As long as you have 1 digit, a thumb, an index finger, you can check and look at what are the gland substances looking like. Is it thick? Is it clear? Does it look like olive oil? You start with those 4 things. Then you're going to start loving it because you're going to start using those tools and you're going to start treating patients. You're going to start seeing results. And then you invest in some of the other technologies. You invest in osmolarity, and that's an added piece to the puzzle that looks at the balance of the tear film. You add MMP9, looking for inflammation. You add meibography, and then there's other technologies out there that are allowing you to get 5 different things very quickly. And pretty soon, you're adding year after year new technology, becoming more passionate about managing it. And so I wouldn't tell you to go ahead and go out there and buy everything you need, but everyone in this room can manage or treat or diagnose ocular surface disease. After you diagnose it, then it's deciding on how to treat it. Mark talked a lot about MGD, talked a lot about looking at Demodex blepharitis. Very simple to have the patient look down. When you diagnose dry eye, I wouldn't discount the fact that we have really good artificial tears out there. And with an artificial tear, I would encourage you and ask you to prescribe these. Don't tell your patient to go to the pharmacy and just pick up an artificial tear. Hand them a sample. Get comfortable with ones that you like and use, and then prescribe them through your patients. Yes, they're over the counter, but if you prescribe them, they're going to utilize them in a way. And these are very adjunctive medications or adjunctive therapies with the other things that we're utilizing. So you have lipid-based ones, which will help with patients that have MGD components. You have emulsants, which are more useful for patients with aqueous deficient, those types of things. But my advice would be make sure that you're prescribing these so they just don't pick up whatever they can over the counter. And then we move into anti-inflammatory treatments. If I see staining on the cornea, that to me equals inflammation. Is it always coming from ocular surface disease? No, not always, but staining equals inflammation. And if you've done your testing, the things that we've talked about a few minutes ago, there's inflammation there. We have some great anti-inflammatory agents. Our immunomodulators, we have a variety of different cyclosporins out there using different types of vehicles to get the cyclosporin to where it needs to get to. Cyclosporin being a very unstable molecule, but with some of these new technologies, new ways to deliver it to the surface, we're seeing really good results and really fast results. We have lifitegrast, we have topical corticosteroids as well that can decrease inflammation. And then we move into more advanced therapies. And this isn't going to cover everything, but we have nasal sprays that can trigger the LFU, the lacrimal functional unit, produce new healthy tears for our patients. Punctal plugs, we even have lacrimal fillers now. You can do a permanent plug. You can fill the punctum with a lacrimal filler, a hyaluronic acid, to be able to block it in a comfortable way that can last for about 6 months. Amniotic membrane grafts as well. And then some other things that aren't listed up here. We have things such as autologous serum drops, PRP drops for our more advanced ocular surface disease patients. When we think of varenicline spray, this has been around now since about 2021. To me, this is a perfect fit. In my practice, I see a lot of glaucoma. And I'm always looking for ocular sparing types of treatment options. And Celine and I have talked about this many times. What do you choose for ocular sparing options? Well, Mark talked about a bunch of ocular sparing options: thermal pulsation, heating and expressing, IPL. Those are all ocular sparing nutraceuticals. And then you have something like this, varenicline spray, twice a day dosing, where the patient will use this to stimulate new healthy tears through that lacrimal functional unit or the trigeminal nerve. Again, ocular sparing for glaucoma patients. So my case study, of course, leading into this is about a glaucoma patient. And I mentioned earlier that no matter what type of practice you're in, you're going to see ocular surface disease. In my practice, I'm doing cataract workups, refractive workups. I see glaucoma all the time. I don't necessarily ask to have dry eye sent to me, but it walks in the door every single day for each one of these types of patients. Every one of our patients that comes in for an evaluation, whether it's for glaucoma, cataract cornea, refractive, fills out a speed questionnaire so that we can start to identify if they have ocular surface disease or dry eye symptoms. And then we put them through that workup, along with, of course, the thing with the glaucoma patient, protecting their vision. And so this was one of those patients, a 71-year-old female patient that's been taking a prostaglandin for a long, long time. You can see for about 25 years. Best corrected visual acuity, 2025. And then intraocular pressure in our clinic was 17 and 18, down from a Tmax of 31 and 29. That's a good drop in intraocular pressure on that PGA. I mean, any day of the week, I'd feel pretty comfortable that I have that patient fairly well controlled from 31/29 down to 17 and 18. You can see pachymetry being thin and then gonioscopy looking normal there. The problem is this patient was progressing. And I know it's hard for you to see on those visual fields and OCTs, but the OCT was progressing, temporal superior as well as temporal inferior. And the visual field, the pattern standard deviation, was increasing year after year. That paracentral defect or that central defect, it's real glaucoma. If we're basing it off of the AAO guidelines, that's severe glaucoma. And this patient slowly progressing, even though we've lowered their pressure from 31/29 down to 17 and 18. Surface doesn't look good. You can see the cornea there, there's some staining, so I know I have some inflammation present, probably because of the long-term use of the prostaglandin. And so we have a little bit of a conundrum here on we have a low pressure, or we feel like we have a low pressure. I don't want to add more medication to this patient. The surface already doesn't look healthy. They're progressing, they're getting worse. I can't let them walk out the door. And so what are our options? What are our considerations? Because we really have to do two things. Number one, we have to make sure that we address the ocular surface. And number two, we have to make sure that we treat the glaucoma. Two different things that we have to take into account. And so for this patient, I like to think of it in two ways. I like to think on one hand, what are my glaucoma treatment options where I can try to minimize the glaucoma treatment burden? And we have things like SLT, we have things like drug delivery, we have minimally invasive glaucoma procedures. Those procedures, although we're treating IOP, we're treating the ocular surface as well. And then on the other hand, what do I have from an ocular sparing standpoint that I talked about earlier, whether it be from in-office procedures to something like a varenicline spray? And so for this patient, what I elected to do was, let's give him a drop holiday. We did an implantable implant, a glaucoma insert that releases medication, taking the place of the prostaglandin. And that won't last forever. We're eventually going to have to manage or do something different, but it's buying me some time, giving them a break from the prostaglandin analog to clean up the ocular surface. I started them on the varenicline spray, so twice a day, to try to produce some more healthy tears. And then I went ahead and occluded the punctum with that hyaluronic acid or that canalicular gel to allow for hopefully healing of the ocular surface. And then I'm going to monitor this patient very closely. And you can see it, their most recent intraocular pressure check, pressure a bit better at 15 and 16, hoping and looking for stability when I watch the visual field and the OCT. And really probably why this patient was getting worse really wasn't because we were doing anything wrong in the practice, probably because this patient just wasn't tolerating their medication anymore. I know if I'm putting something in my eye, and I start having vision problems or my eye starts to burn or hurt, whatever it may be, I'm gonna take some days off. I'm gonna stop, I'm gonna pause, I'm gonna skip. Compliance adherence was probably what was leading to progression over time. And the hope here is by getting them off the drop, cleaning up the ocular surface, and then monitoring them closely, we'll be able to make an impact for our patients. And so I'll just end with saying, keep in mind, whatever practice you're in, if you see a lot of glaucoma, if you are in primary care, if you're in a commercial setting, whatever you're in, I guarantee you that these types of patients are walking through your door. And we have a lot of good tools based off of a lot of the tools that Mark talked about and some of the tools that I talked about to manage these patients.
I have a question for you. So you're talking about the cross-linking hyaluronic acid that you use for the plug. How long does that last?
So based on what we know, 6 months.
Okay.
That's what the evidence says. I mean, it's possible it lasts longer than that. It's possible it could be a little short of that, but 6 months is the number.
Is it hard to inject it, to put it into the cannula, or?
It takes a little bit of a learning curve. You need to prime it first, so you need to prime it, push a little out, and then once you've primed it, the first time I always say you need to be firm, but not too fast, but you can't be too soft.
Yeah.
The biggest learning
It's a balance.
So right in the middle.
Just right in the middle.
The biggest learning curve is your cannulas, and my sweet spot is a 23 gauge 6 millimeter bent tip cannula, because you can put it in the puncta and turn it sideways and it fits perfectly in that groove. I use a 23 gauge because I do have man hands, like they're big, but they're not strong.
Yeah, they
And
are.
They're huge, right?
Well, hold on. They're big but not strong. That's what a man hand is?
I
Justin,
don't know.
come on.
I'm just saying, I can't push a 25 gauge and I want 0.1 mLs in each puncta. And so a 23 gauge for me, I'd rather dilate a patient and use a 23 gauge and lay it more in there versus a 25 of me like going behind the slit like, right. So
It is
23
hard.
gauge
You gotta
for me
get that
is
thumb strength up
best.
to get,
Yeah.
yeah.
Well,
And
any
if you have
cannula,
if you have
the
more petite
cannula,
hands,
yeah.
it's hard. So Justin's right when he said prime it and push. There's plenty in that system. Push it through so you don't have so much to push and it's not quite as hard.
Yeah.
It's a really, really creative and innovative way to make a plug. No granulomas, you don't worry about them popping out. It's custom fit for every patient. It's easy to remove. We were part of the clinical trial, I'm sure you were too. I was removing them. That force that we had to use, I used to stand on the outside and just push it. So.
And there was
yeah.
improvement in signs and symptoms
Yeah.
in their clinical trials. Is that
Yeah.
accurate, as I recall?
Yeah, good stuff. So one more question. You have like 10 seconds. So there is the neuronasal spray, like the varenicline. There's some newer ones coming out too that are also, but those aren't drop sparing, right? That are going to create that. So this is the only drop sparing that we have.
Yeah, and there's some new ones definitely on the way that are going to utilize or attack. There's a cold receptor or a cold receptor sensor on our corneas that's going to produce basal tears or our normal healthy tears at twice-a-day dosing. There's a keralytic that's coming from an MGD standpoint to break up keratin plugs down in the glands and on the surface. So, if we had time, we could talk for another 2 hours. There's so many things that are coming that are going to be, exciting to help our patients with ocular surface disease.
Thanks.
Okay.
Are there
So-
any questions? Good. Okay, Cecilia, you're all set.
I was going to say, not right now. And so we're going to continue, and we are definitely doing the whole kitchen sink, because now I'm jumping into presbyopia. The Amuse-Bouche Fest continues.
Yes.
This is what we're doing. So we're not diving into every single part of this, but we are going to talk about both, presbyopia drops as well as we're going to touch base on intraocular lenses. But I want to start with presbyopia drops first, because I think that this is something I want to try to get a little bit more of your excitement coming back regarding this. I know that, we had one drop that made it to the category and it was a little lackluster, maybe didn't live up to what we were hoping. But I think we need to think about this exactly like we do with multifocal contact lenses. Multifocal contact lenses, one, does not work for everybody, and every type of lens does not work for every patient, right? So if we think about it in that respect, knowing that we've got a number of different drugs that are coming, topical drops that are coming that work a little bit differently, right? It should make us more excited to know that we're going to have options for our patients. And I intend to see this as a patient who I find one drop works immediately may not be the same drop that we're using 4 or 5 years later, because
their pupil size is going to change naturally, the cataracts, things like that. So it's a category, and I want us to think about it like that. But right now, the one that is most closely through the pipeline that will be making it into our hands is Closey, which is from Orasys. It's the 0.4% pilocarpine. It's actually it's FDA approved back in October of 2023. They took a moment, they took a beat, right, to think about how to approach getting it into our hands a little bit more thoughtfully, just to make sure that we are set for success and not for failure. It should be, it's actually being launched next week at SECO, so look for them there. That is something that we will be getting into our hands shortly. Right behind that, in a completely different molecule, is the aceclidine 1.75%. It has been, NDA has been accepted in October of 2024, so again, that's the one that's coming up next. And then we have a whole other group, which is carbachol, 2.75% carbachol mixed with bromonidine 0.1%. Phase 3 trials are currently underway. Now they're all working in the same mechanism of we're going pinhole effect, right? So that is the same, but the molecules, the muscles that they're acting on, to what percentage and to what degree is different between all of them. So we'll see where these fit in. We know FDA trials are FDA trials for a reason. It's not necessarily how we're going to practice. So I'm excited to get some of these in my hands so I can come back in a year or two and have a whole other discussion with you guys about where I'm finding that these are working for our patients. Now, to pivot off of that, many of us are, this thing doesn't like me. It's just me. There we go. I got a finger. It's fine. So talking about different lenses, these categories continue to grow. The multifocal contact lenses that came out when I first graduated, or that existed when I first graduated, oh, thank you. Were you hiding it? Oh, that one's not connected? You were just faking me out. This is great. So multifocal IOLs that were in existence are crystallines and some others that have gone by the wayside, definitely under-delivered for where they promised as well. Our IOLs at this point continue to become better and better, and with that, us as optometrists are the ones that are giving a lot of the information that's important for our surgeons as far as who is a good candidate for which lens and which one's going to work the best. I'm not going to go through every single lens and what's in every category. I think the biggest thing for us to take away from it is that there are options that may be appropriate for each patient, and letting your surgeons know either that you are co-managing with or that you work with in clinic, right? Know about the patient, the things that we know. Did they fail on multifocal contact lenses? Do they have trouble with dealing with progressive IOLs? Can they stand monovision, right? Those are things, as well as patient personality. We want to set the patient and the surgeon up for success, so those little pearls that we can pass along then helps them understand which one of these lenses is going to be probably the best for the patient, or are they maybe just not a good candidate for a premium IOL. Now with co-management itself, patients, this was a study that actually asked patients who had IOL implants, and what it came out of it was 53% of the respondents said that visual quality was the most important outcome to them, versus 45% who said spectacle independence was the most important to them. Does that surprise any of you? Any of you guys? No, I'd say I agree. One thing I would say though is that 2% that says minimizing dysphotopsia, they don't know what it is. Nope, and those people who have dysphotopsia, they will tell you that is the most miserable thing, and they want that gone. So while I agree with, these are definitely the top 3 things that are important to our patients, I think it's good to chat with them, find out what's the most important thing to them, because everybody's different, and I think that's really the big thing to take away from that. So let's look at a case study. I have a 65-year-old female who loves being active, plays pickleball, and is still working. Gonna throw it, I don't know.
I don't get this.
I played it once,
Yeah, it's also the fastest way to break your knees, and
I played it once and I got a concussion. Yeah.
You know what?
Blame Vin Day. He hit me and I ran into the
I
ground.
think that I'm going to start that up with my wife.
I'm punching her for you.
So patient doesn't currently use glasses except for OTC readers and really doesn't want to. So this is our patient who might be motivated to try something that is going to give them a better range of vision, better functional vision. We see that she's still working, so most of us working includes at least some range of vision right here. Pickleball is going to be our range out there. So we want something that is more of a complete range of vision for this patient as far as what's going to probably make them happy. Patient is noting some difficulty with glare at night and seeing the pickleball, which doesn't make her happy. Vision, overall, we see that it's not too bad, 20/30, right? But the glare is getting down to 2150 and 2200, so we consider that a significant cataract, right? Visually significant at this point. Everything else, super happy. Macula looks good because that's important. That's going to tell us things about possible lenses that we can use. So it was decided to do a full visual range PC-IOL. So this is a newer category of IOLs that has come out in this last year. Underwent cataract surgery with this FVR PC-IOL, which is a non-uniform distribution of refractive echolets. So as opposed to having very defined, consistent changes between the little areas of diffraction, so near and far, this one is a little bit more erratic and non-uniform. That's why it's described that way. Vision outcomes, 2200 in distance, 2020 in distance, not 200, she'd be angry at me. 2020 in intermediate, J1 uncorrected, both eyes. So overall, this patient is very happy with her vision and her pickleball game improved. There we go. And back onto you. I got us back on track, don't worry.
Yeah, thanks.
That's why I'm the closer.
All right. We are in the final stretch. Hopefully you guys got a little bit of a taste of everything, that's kind of the new and exciting things that are happening, especially in eye care. I need you to answer these next 4 questions, but more importantly, I just want you to realize that as clinicians, it's like we can't stop being innovative. We can't stop offering for our patients, because once we stop offering to our patients, then they're going to look for somebody else who's going to do it. So every one of these things should be something you should be thinking about in your practice.